Today I'll be covering a very important topic in cardiology, that is atrial fibrillation. So atrial fibrillation is characterized by disorganized, rapid and irregular atrial contraction, activation, irregular atrial activation with loss of atrial contraction and irregular ventricular rate determined by AV nodal conduction. Risk factors may be physiological and pathological. So the physiological risk factors and pathological risk factors. Now I want all of you to imagine the room where you are sitting is the left atrium. So now imagine that the left atrium is beating at 150 to 200 beats per minute. Now all the impulses with which the atria is beating cannot be get uh, transferred to the ventricles because there is something known as AV nodal delay. So because of the AV node, all the impulses from the atria are not going to the ventricles. Also, because the contraction rate of the atria is so high that all the blood in the left atrium cannot be emptied into the left ventricle. So there is stasis of blood in the left atrium, which will ultimately lead to one of its complications known as LA thrombus. So it is disorganized, rapid, irregular atrial activation. Atria is beating so fast that it cannot contract fully. So loss of atrial contraction and irregular ventricular rate. This irregular ventricular rate is because not all impulses from the atria are going to the ventricles, determined by AV nodal conduction, or you can call where there is commonly known as AV nodal delay. Now paroxysmal AF and persistent AF. So paroxysmal AF usually starts spontaneously and ends within a period of 7 days. Persistent AF exceeds for longer than the period of 7 days. Now the sites are pulmonary veins, myocardium around the superior vena cava and the coronary sinus. The important clinical features of atrial fibrillation are irregular pulse. The reason which I explained previously was that all the atrial impulses are not going to the ventricles, so the ventricular rate will be irregular. So there will be various volumes of pulse. The pulse volume will vary, which I'll explain in the subsequent slides. Apex pulse deficit and absence of A waves on JVP. A waves are due to atrial contraction. Because the atria is not contracting fully, their A waves are absent. Now imagine that the atria fire at the rate of 150 to 200 per minute. Now not all of them will reach the ventricles because of AV nodal delay. Now because all the blood is not reaching the ventricles, the ventricular rate will vary. Because the ventricular rate will vary, the diastole rate, the duration of diastole of the ventricle will vary. So some of the diastoles will be short, some of the diastoles will be long, and some of the diastoles will be normal. Now the duration of the diastole depends on the filling of the ventricles by the atrial blood, which also depends on the rate of the atria and the impulses which are actually reaching the ventricles. So lack of atrial contraction will lead to stasis of blood in the left atrium and lead to thrombus formation. This thrombus will embolize to the brain, lead to recurrent cardioembolic stroke. Now this LA thrombus can be detected either by 2D echo, or the best way to detect this is TEE. Coming to the treatment of atrial fibrillation. If the duration is less than 48 hours and no structural abnormality of the heart is present, anticoagulation can be started immediately. If the duration is more than 48 hours or if it is unknown, anticoagulation should be started 3 weeks before and 4 weeks after cardioversion should be considered. Because if you cardiovert the patient and if the patient has LA thrombus, that LA thrombus will embolize during cardioversion and lead to stroke. So that's why prior anticoagulation is needed for if the duration of atrial fibrillation is unknown before cardioversion. It is very important to rule out LA thrombus by TEE and continue anticoagulation thereafter. Now, this is a very important point where questions are asked many times, which is the SHAD-VAS score. Now, this SHAD-VAS score is mainly because of determining anticoagulation in a case of atrial fibrillation. Now, C stands for congestive heart failure or LV dysfunction. H is for hypertension. H A is for age more than 75 years. D is for diabetes mellitus. S is for stroke, transient ischemic attack or thromboembolism. V is vascular disease. Age is between 65 to 74. Sex category, that is a female sex. Just now imagine, just remember that age more than 75 and previous history of stroke contains 2 points. Rest all it is 1 point. So now score of more than or equal to 2, you consider anticoagulation can be considered. So from the oral anticoagulants, direct thrombin inhibitor is dabigatran, factor 10A inhibitor is rivaroxaban and apixaban, vitamin A antagonist is warfarin. These newer anticoagulants do not require monitoring, but warfarin requires monitoring with PT-INR, and the INR should be maintained between 2 to 3. For valvular heart disease, the INR should be maintained with between 2.5 to 3.5. Now coming to the complications of atrial fibrillation, the first one is syncope. Because of the variation of the heart rate, ventricular rate and variation of diastole, the irregular rhythm and irregular pulse volume will lead to syncope. Thromboembolism because of LA thrombus will cause cardioembolic stroke. Angina because of, as you know, that the coronary blood supply to the heart occurs mainly during diastole. So when the heart rate is around 150 to 200 beats per minute, the rate is more, so the effective direction of diastole is reduced. Therefore, the blood supply to the heart via the coronary arteries during diastole reduces, and the increased heart rate will ultimately lead to increasing oxygen demand, which will lead to anginal symptoms, hypotension, pulmonary embolism, and worsening of cardiac failure. The main basis of treatment is rate control. Rate control is achieved by beta blockers, calcium channel blockers like verapamil and diltiazem, and digoxin. The indication of digoxin in case of atrial fibrillation is atrial fibrillation with heart failure. Rhythm control. The rhythm control can be achieved by class 1 sodium channel blockers like flecainide and disopyramide, catheter ablation of left atrial regions and the pulmonary veins, surgical removal of the left atrial appendage is the last resort.